Okay, so we are going to start this session with Chapter 9, which is canine and feline anesthesia, which a lot of this we have covered already. So some of the beginning is going to be review because weeks 1 and 2 of last term we had talked about patient preparation, which I had already gone over. Make sure also when you're looking at these PowerPoints that you review the notes underneath. So again, part of preparation, go through your checklist, your physical exam, the history with the owner, especially any previous anesthetic episodes. Think about your breed considerations, brachycephalics, sighthounds, pediatric versus geriatric. Make sure to ask about owner over-the-counter medications like Benadryl and aspirin. So if you have some sort of a checklist, you're less likely to forget things. So in this class, I do not make you memorize protocols. They're going to be different for every clinic, every doctor. So normally, like I've told you before, you're going to start at a practice and they're going to have a pre-approved list of pre-meds, induction agents, inhalants, medications to send home. So it's always imperative to make sure you're familiar with what their protocol is. So usually any protocols are going to come with the drugs, the dosage in mg per kg, and remember, very important, your IM dosing is always going to be higher than your IV dosing. So that is going to be very different. You have to make sure you choose the appropriate one. So your protocol list will have any mg per kg, what route, IV, IM, and this is usually pre-approved by the doctor. Most of the time, I will always at least have another technician or the doctor check my dosages. After you check your dosages, you also want to make sure when you draw them up, someone checks your volumes. Because you can do great math, but then mess up how much you draw up. And it is not a sign of weakness to have someone check your medications. So I always double check them. You need to also check your oxygen flow rates, your fluid rates. Always make sure you flush your fluid line. Make sure that we have done the minimum blood work required, that we've gone over the patient status. And one thing, this last line is very important. Modified protocol for ill, pediatric, or compromised. I am not a fan of cookie cutter anesthesia. I've heard of places that'll say every 20-pound dog gets this much acepromazine, for example. But you can have a 20-pound puppy. You could have a 20-pound Shih Tzu that's 15 years old. Those dogs are both 20 pounds, but those dogs are very, very different in their presentation. So if you see what I'm saying, weight is only a very small piece of the puzzle. We have to look at the whole patient, the whole database. So don't just apply weight to the protocol. You have to look at the drugs, the patient, the circumstances, the procedure, and be willing to modify that protocol. So at Purdue, we had our average dosages, but we could always give a little less, a little more. And remember, you can always give more. I would way rather underdose and have to give my patient more, because if you overdose, a lot of the drugs are not reversible and you are stuck with the side effects. So some ways that we minimize adverse effects under anesthesia, and this is an important slide. Can we treat anything prior to anesthesia? A big one is dehydration. I don't know how many times in ER a dog comes in because they ate a towel, a string, a toy, and they've been vomiting for several days. Now, how many times does your dog vomit and you ran to the vet the first time your dog vomits? A lot of people are like, they got into something. They don't feel good. So sometimes these dogs are vomiting for 2 or 3 days before the owner is alerted. So a lot of them come in dehydrated. We will sometimes, if the dog is not in imminent danger, we will put the dog on fluids for 12 hours and then go to surgery. So if you can treat anything, blood transfusion, dehydration, hypothermia, low oxygen, put them in an oxygen cage. So there's lots of things that we can do ahead of time to try to minimize this. Always base it on the database. And again, here is my soup analogy. Use a balanced protocol. It is always going to be much safer. There is a very, I don't want to call it a misnomer or a false thought that using only one drug is safest for your patient. You really want, if you use ACE with morphine, you're going to use less ACE and less morphine than if you use this alone or this alone. Anytime you use a drug alone, you are going to see the most side effects associated with that drug. By putting two drugs together, you enhance the effects of each drug and you can use less. So that is balanced protocols, multiple agents. And then whenever, like say this is my syringe and I drew up medication and I'm getting ready to give it, whether it's IM, IV, sub-Q, PO, whatever, I'm going to look at it and go 2 mils, 2 mils. So you always have that last check just to make sure you drew everything up. Make sure all your syringes are labeled. Usually at least a part of the name of the patient. If you got a patient like Fluffy, are you sure that's your only Fluffy of the day? So we always go with the minimum amount that we can give. So remember, I said when we give propofol, it's to effect. If I have 20 mils drawn up, I give about 10 mils. I give half and wait, then half, then wait, then half, then wait. That's just typical. Now, I have had a patient that is flat out from pre-meds. It hit him very hard. And I normally, give half. Sometimes I give a quarter. So if you have the feeling that the patient doesn't need a half, maybe you don't have to do it. Most of the time they do. Okay, so I spent a lot of time last term going over the induction agents, but I want to talk about how we can give induction agents. Now, your most common route is IV. By far, intravenous is how we give propofol, alfaxin, Cat-Val, but there is different protocols that you can give IM. Now, each induction route I'm going to talk about has advantages and disadvantages. On the study guide, I'm going to want you to be able to identify what is different about these routes. So, when you give an IM, an anesthetic agent like Kitty Magic is dextrometor, ketamine, and butorphanol. The nice thing about not watching these live, you can pause that and write that all down. Kitty Magic is an IM induction, ketamine, dextrometor, butorphanol. Now, what is associated? That's just one protocol. There's different IM protocols. What is associated with IM? What's going to happen is they're going to be awake, you're going to give the shot, and they're going to start to fall asleep gradually. One of the disadvantages of IM is you have little control. Once you do an IM induction, you give it and you got to wait and see what happens. I can't like give it slower, faster. When you give it in the muscle, it's a bolus of a dose. Now, you can, if it's not enough, give more. I will tell you, a drug like Kitty Magic can kick in as soon as 1 or 2 minutes, and I've seen it kick in 20 to 30 minutes. Whether you give more is your doctor's decision. So if I go back there and the cat's still staring at me like, whatever, I'm going to give more. But I'm always going to check with my doctor. If you got it too deep and you used a drug that can be reversed, you may do that. You're going to see these graphs here, which will be helpful. It's going to start, what it shows you in the bottom is minutes that have elapsed. And then it's going to be at 0 minutes, you give the injection. Now you see they're awake and this slope starts to go down. Light, optimum anesthesia. This, if you look at the bottom, this injection took about 20, 22 minutes to reach peak effect. Now, what happens here, drug starts to wear off gradually. You get a gradual recovery. So this animal with this protocol took about an hour from time of injection to recovery. Now, remember, I told you what's very important on the left. Remember, we have stage 1 and stage 2 are considered awake and then excitement phase. They just don't write that on here because they don't really hang out in excitement. Then you have light anesthesia, which is stage 3, plane 1. This pink is optimum, which is stage 3, plane 2. And then we've got this darker purple, stage 3, plane 3, which is, remember I said is too deep. If you get way down here, you don't want to be there. Remember the first day of anesthesia, I said light, dead, and I said where you want to live. Okay? Somewhere in the middle. I don't want them waking up and feeling anything, and I don't want them dead. So my job as an anesthetist is to keep them in this range. But like I said, when you give an IM shot, it's going to take a while to kick in. Now let's look at an intravenous injection for induction, like propofol, pentothal, alfaxin, all fit in. Okay, so this is typically used for short procedures. Drug is given to effect because you're going in the vein, so I can give it and stop. I can give a little more and stop. So drugs, propofol. We do not use methotrexate anymore. That was called Brevitol. We do not use that. Thiopental. But on this slide, if you want to write in alfaxin, that would be good. Alfaxin is an IV injection. It's ultra short. Anesthetic depth increases rapidly, then decreases gradually. But the anesthetist has control. So let's go back to the chart. They're awake. I start giving the propofol IV. All of a sudden, we go from awake. Within 1 or 2 minutes, we're pretty deep. We stop giving it. Now, let me explain something on this chart. Right here, it's showing you awake, goes deep. If you stop giving it, they're going to wake up in about 10 minutes. What is not on this chart is usually right about here, you're going to intubate. So do you see as your injection wore off, your inhalant would keep you in this pink range. That would be you intubating, turning on the isoflurane. So right now you have peak, and then it wears off, and then they're going to wake up. Now this chart is showing you 1 injection with no inhalant. You give it, 10 minutes, they're awake. And again, this is like little boluses here and there, titrate to effect. Now, there is something, so that was intravenous injection. But today you want to keep them asleep. There's general anesthesia that you can do IV, and it's called TIVA. You need to know what this stands for. Right here, total intravenous anesthesia. It means that the whole anesthesia is being maintained with these intravenous agents. This would be propofol or alfaxin, maybe fentanyl, but these are the drugs we typically use when we want to do a TIVA. Now, patient is induced, they go to sleep. Now, you can put a tube in them. This is showing you that you did not hook up gas. So you just gave all intravenous. You gave it every 3 to 5 minutes, right? Short to moderate anesthesia. But if you look at the chart, this will kind of explain it. So here, I gave it. I got them to stage 3 plane 2. They intubated. I started turning, the injectable wore off. Oh, they're waking up. I got to give some more. Give another shot. Oh, they're waking up. They need more. Now here is the bigger slope. You can see there was more given. And if you stop giving it, they wake up. So there is TIVA like this, just total intravenous. And I should say, these are following the 5-ish, 10-ish mark. If I get to this one, this is TIVA by CRI. Now the difference is you're giving total intravenous anesthesia still. Patient is induced to effect, do everything the same. And then anesthesia is maintained with a constant drip. The previous way, you give a bolus and you stop. This way, you use a syringe pump and you give a little bit, continuously drip, drip. You can do a fluid pump. You can do it with a syringe pump. Either way, you still achieve this. So you give the drug, go to sleep. Now this one, instead of being awake, asleep, they're kind of like, it's kind of like low peaks. Okay, I am going to stop at inhalant, and I'm going to have to make the rest of this tomorrow afternoon because I literally cannot talk. So what I will do is I will send this out with the PowerPoint and get this out to you. And I have an email that explains everything. So we will pick up at inhalant in the next video.